Welcome to the Hemostasis Disorders seminar, and I think we'll just go right into the questions. So,
Okay, I see this one proved to be a bit tricky. It was just a play on words. So the first one, it's not true because when we speak about anything primary, it means like in this case, we're talking about something that's a problem with the person's like innate ability to coagulate. So external factors wouldn't make sense because that comes under secondary thrombophilic state. So that's why the first one isn't true. The second one is actually true, and I don't know if this particular syndrome was mentioned in Scripta, but I do remember it being mentioned in the PPT, and like Professor Kubova made a point out of it, so that's why I felt like I just added here. So there's increased platelet aggregation not only in response to ADP but also epinephrine, and this statement is true. And the third one, everything is correct until the point that it says protein S. It's actually protein C, activated protein C, which is responsible for the degradation of factor V. So make sure you read the whole statement. Anyone has any questions? Okay, I think we can go to the next one then. Okay, that's great. All of you got it right. So the first one obviously isn't true because whenever we speak about increased coagulability, there should be increased platelet function. So decreased platelet function wouldn't make sense. The second one, they do promote production of hepatic coagulation factors, but they don't sensitize factor V to ABC because if they did that, it would mean that they're actually helping the person, like not coagulate unnecessarily and stuff. But over here, so the actually what is true is that it's making it more resistant and not sensitizing it. And then the third one, of course, is true because it is true. There's nothing more to it. Anyone has any questions? Okay, then we can go to the next one. Okay, so I see half of you picked the right one and half of you picked that one. So obviously the first one, it's not true because it's more common in women than men. Second one is true. The antiphospholipid antibodies are binding to beta-2-glycoprotein. Third one, again, it's not true because it's been mentioned that there's a two-hit hypothesis. So you have to have, in addition to these antibodies, also a situation that promotes increased coagulability. So it could be some sort of malignancy or infection of some sort, etc., like many reasons. Now, the fourth one, the reason this is not true is because skin mottling is a term that's more used for sepsis. In regards to antiphospholipid syndrome, there's a particular term called livedo reticularis, but you could argue that maybe it is. So it's somewhere on the edge, but I just wanted to like bring attention to the fact that like there is a specific term that's present for this. Anyone has any questions? Okay, then I think we can move on to the next one. Okay, so the first one is not true. It's actually the opposite because, uh, like it's mentioned in Scripta, acute DIC goes through these three phases. So first you have the prothrombotic state, then the bleeding state, then hypovolemic shock as a result of the capillary leak syndrome, etc. So, because of that, acute DIC is characterized by increased bleeding, whereas chronic DIC, which you would find in states of malignancies, is characterized by thrombosis. As for the second one, it is true. I don't think it requires any further explanation. The third one, again, this is true because capillary leak syndrome, like it's in the name, like increased permeability, therefore substances are leaking out. And as a result, you develop capillary leak syndrome. And the fourth one is not true because this should actually be causing hypotension because fluids are not moving into the vessels, they're moving out of them into the extracellular fluid. Yeah, does anyone have any questions? Okay, I think we can go to the next one. Okay, let's see. The first one, again, it's just wordplay. D-dimers, they're actually fibrin degradation products, not thrombin degradation products. So make sure you read the question carefully. Then the second one is true. It can be performed up to 12 hours after the onset of symptoms. And the reason that there's a time limit on this is because after a certain point, when the myocardium undergoes so much ischemia, it's not viable anymore. And the like recanalization of the vessel or this intervention is not going to do much good because you're not going to be able to get the myocardial function back, and it's going to result in a scar. Third one, I'm happy you guys didn't pick it because it's antithrombin 3 and not antithrombin 2. Then the fourth one is true. And then the fifth one, it isn't because it primarily works on factor 10 and thrombin factor 2. So yeah, that's it. Does anyone have any questions? Okay, I think we can go on to your part 13.
Okay, so disorders of coagulation. When I say, okay, you can have bleeding disorders, but when I talk about disorders of coagulation, I usually mean like the third like phase of coagulation, the hemocoagulation with the clotting factors. The most common is hemophilia is not correct. Actually, the most common is von Willebrand disease. It's more common than hemophilia. I think you'll find it in the text on Scripta that it's more common, and also Dr. Kuba usually emphasizes on that a lot. Can be acquired by the use of broad spectrum antibiotics is correct, actually. And the reason being that in broad spectrum antibiotics, it decreases the intestinal flora. And this produces, and the intestinal flora is responsible for the production of some specific type of vitamin K. And in that case, you can regard it as like vitamin K deficiency and then acquired disorder of coagulation. Can be seen in DiGeorge syndrome. DiGeorge syndrome, I think this is because I remember we got it in our test, but DiGeorge syndrome is classified by hypocalcemia. It has hypocalcemia as one of its feature. And remember that like hypocalcemia and also like severe hypocalcemia usually results in an acquired disorder of coagulation. Hemophilia is an autosomal recessive disorder. I'm glad no one picked that. It's an X-linked recessive disorder, and that's why more males have it. Can be seen in Wiskott-Aldrich syndrome is not correct. Wiskott-Aldrich syndrome is a bleeding disorder, and there's something wrong cascade, but it's not in the hemocoagulation. It's not in the factors. It's in the thrombocytes. It's a type of thrombocytopathy, which is like a qualitative disorder of the thrombocyte. And Duke test can be used to differentiate between hemophilia and von Willebrand disease. It is correct because in bleeding test will be prolonged for von Willebrand, but in hemophilia A is normal. This is because the primary thrombus in hemophilia A is completely normal. It's just a of factor 8. But in von Willebrand disease, there's a problem with the formation of the primary thrombus. Because if you remember that the von Willebrand factor, it's like a glycoprotein that it is a carrier for like factor 8, but it's also required for like platelet adhesion. Like it acts as a bridge between the platelet and the damaged subendothelium. So without that adhesion, there's no primary thrombus formation, and that's why it prolongs bleeding time. And that's why Duke's test can be used to differentiate between both of them. Is this clear? I hope so. So we can continue on to the next question. I'm sorry here, I meant prevention of pulmonary embolism, not pulmonary only. I don't know why I mentioned just pulmonary. Prevention of pulmonary embolism should have an INR of 1. Okay, so prevention of pulmonary embolism should have an INR of 1. No. INR 1, usually like 1.7 is normal, but usually we keep it in the higher INR to prevent the risk of thrombosis. So we usually give them warfarin, and warfarin should be kept of 2 and 3, usually. Prothrombin time is increased in hemophilia is wrong because prothrombin time essentially like measures the extrinsic part of the coagulation cascade, and hemophilia is a disorder with the intrinsic part mainly. So it's not measured with the prothrombin time, but APTT, which is the next one. APTT is abnormal for hemophilia. Prothrombin time is completely normal in hemophilia. The thrombocyte count is low in I think everyone picked this. It's correct because DIC is a consumption coagulopathy. So in the first stage, you have increased thrombosis, and then the thrombocytes are consumed, and then you have the bleeding part. If this is clear, we can go on to the next question. If you guys have any question, you can just type it in the chat. We'll look at the chat at all times, so don't worry. Or you can open your mic, it's fine. So next question. So disorders of the first phase of coagulation, which is the the phase where it's like abnormalities with the vessel wall. So vasculopathies, and the first phase we are talking about the vasoconstriction. Can manifest as bleeding under the periosteum is correct because in acquired versions of the disorders, there is avitaminosis C, which usually in adults will manifest as the disease scurvy, which is like gingival bleeding. And robot, which usually manifest as bleeding under the periosteum. So that's why it should be correct. Teleangiectasias. Oh, I think I made a mistake. never mind. 1 second. Telangiectasia hereditaria hemorrhagica, which is basically the Rendo Osler disease, is an acquired version. No, it's a primary version. Can manifest as pulmonary bleeding and glomerulonephritis is correct. It's but that disease, yes, it can manifest as the not this one, sorry, Goodpasture syndrome can manifest as pulmonary bleeding and glomerulonephritis. And I don't know why I have Gaucher's disease as correct. It's not correct. I'm sorry for this mistake. It's part of the second phase, the hypersplenism. So please never mind that. It's not correct. So it's only the first option and the third option. I'm so sorry again. I don't know why I have that. But we go on to the next question. Okay, I think this was easy. Quantitatively caused by irradiation. Yes, it decreases the overall thrombocyte count. Can be seen on artificial valves is correct. Usually it damages the thrombocyte like structure, so thrombocytopathy. And yeah, this disease thrombocytopenia is a qualitative disorder, and it's not a problem with the coagulation factor, it's a problem with the thrombocytes, either quantitative or qualitative. So last question. Okay, so hemophilia B is not the most common. The most common again is von Willebrand disease, but the most common hemophilia is hemophilia A. So that's one thing. Hemophilia usually manifests as bleeding to the joint, especially the knee, so hemarthrosis. A that may lead to the IC. Yeah, it's an acquired disorder of hemocoagulation. Usually it's a problem during like delivery. There could be an abruption of the placenta with like embolization of the amniotic fluid. And then again causes the stages of the DIC, the coagulation, and then the severe bleeding. And most of the time it can cause death of the mother and the fetus. Hemophilia A is a deficiency of factor 11. No, it's a deficiency of factor 8 and can happen in liver failure is correct because liver is responsible for the production of many coagulation factors. And if you have liver failure, then you have to assume that they will have a problem with coagulation. Usually, one of the tests that or one of the criteria in the diagnosis of liver failure is actually to do a prothrombin test or an INR, and usually it's abnormal in those people. And yeah, it's in the Child-Pugh score, and it's one of the and yeah, I think that's all. So thank you guys so much for attending. I know the seminar was not long. It's only two questions, and we wanted to make as many questions as possible, but yeah, it is what it is. So, but thank you guys for attending. I hope you learned something.